Hi guys, hello and welcome. We've offered this tool as a bit of a complimentary download for hospital providers, frontline clinical staff, ready to begin workshopping ways to optimize the management of elective waitlist surgeries. Before we get into the tool though, I just wanted to spend 2 minutes introing who's here on this video. Myself, Brett Tabbo, I'm one of the founders of Aginic. Aginic's company started 6.5 years ago in the analytics space, very much with a focus on healthcare. Our vision really is to, take a lead in the way that healthcare analytics is done within Australia. We really want to reimagine healthcare, particularly at the moment, embrace the opportunity to, strive for a stronger, more resilient health system and do what we can when it comes to data. And we think that's really important. We have a fairly unique way of working at Aginic here. We do most things in a very agile and iterative manner. We really embrace the usage of things like design thinking and involving the end users, so very much talking to the frontline clinical staff, the coups, the nums, that kind of thing. What we did realize though is we needed more than just us. We needed a partnership to really tackle the healthcare sector, and to do that, we've partnered strongly with Green Cup. And I've got Sean here, who I'll let him introduce himself in 2 seconds from Green Cup. We've sort of brought to the party the data and our understanding of health analytics. What Sean brings though is a real deep understanding of health as a vertical, and his healthcare expertise kind of forms a real good unison with us with our data analytics. So I'll hand over to Sean now.
Thanks, Brett. Hi, everybody. My name is Sean Lowry. I'm the founder and director at Green Cup. Green Cup's a boutique health consultancy. We utilise clinicians with extensive experience in hospital operations and hospital performance improvement to work closely and form quite strong relationships and ongoing relationships with our clients to actually avoid dropping large diagnostic reports, but actually stay and shift the needle on efficiency, improving quality and access and patient experience with our clients. It's a fantastic relationship that we do have with Aginic. I've been working in the sector for over 25 years and was involved with Aginic and the founders of Aginic from the commencement of their organisation. And they bring tremendous insight and analytical power that Green Cup's able to utilise with its clients to provide great insights to be able to test decisions and certainly inform policy and approaches to achieving what we need to achieve in the health sector. Just before we have a look at the Waitlist Scenario Forecaster, it's quite timely. It's an very interesting week in health. Many people back to work, back to school. We've had thousands of junior doctors join the ranks in the last week. We've had the opening of the STARS service, or the elective surgery and rehab service, just north of the river here in Brisbane. We've got the normal scenario, or the February or the late financial year scenario of public and private hospitals really struggling to meet their contracted targets. And we've had the Surgery Connect contract in Queensland come to market just yesterday. And we're hearing anecdotally from sort of senior surgeons, particularly upper GI surgeons, that are expressing concern about much later presentations and seeing patients with more advanced polyps, for example, due to the 6 to 12 month delay in elective surgery due to COVID. So it's quite timely that we're posting this up and having this conversation. Interestingly, also, the financial pressures across the health system, not just unique to Queensland but across the country, are coming back to bite us, or they're becoming evident in our balance sheets now, with 3 or 4 months to go in the financial year. And we haven't really had the opportunity in COVID to address some of those underlying fundamentals, particularly supply and demand side levers in elective surgery. So we'll talk about a bit about those when and the options for those as we go through the basic scenario forecaster. So I might throw to Sam now to show us what the forecaster looks like in its current format, run through some numbers of a typical regional hospital, circa 600 beds, circa 10 theatres, very common sized hospital across the Australian landscape, and have a bit of a play with it and talk through a few scenarios. Thanks, Sam.
Awesome. Thanks, Sean. I'll just share my screen quickly. Awesome. So if we jump across, as kind of Brett mentioned before, the purpose of this tool is to just provide a really high level calculation that kind of demonstrates the impact that COVID has had on elective surgery wait lists, depending on how long certain hospitals had to shut down for. There's the ability to kind of put in your own numbers and model your own scenario. And then at the end, you'll kind of see that we've put in a little bit of capacity there to start, I guess, playing with different scenarios to start trying to bring that wait list back down to normal or what it was pre-COVID. And so the numbers that we've put in here into this custom scenario is kind of that of a typical large hospital within Australia, kind of around 600 beds, that kind of that size. And what we've kind of said is, you know, before COVID, the wait list would have been sitting at around 266 category 1s, 1,025 category 2s, and 2,010 category 3s. What we've then also had put in is that then your weekly treats for your cat 1, 2s, and 3s is going to be around 56, 40, and 38 respectively. And then for those weekly additions, we've kind of just said it's around 4% higher than what those treats are. And then there's kind of an annual growth rate on those additions of 4% as well. And so what that kind of looks like here is you can see there are 3 different lines there, which is representing your category 1, 2, and 3 wait list over time. And based on the idea that the shutdown date was the 23rd of March and that we spent 9 weeks not servicing any of our category 2 or category 3 elective surgery patients, that's that kind of bump there that you see that you can zoom in on as well, to just kind of show the impact that that has on your wait list when you stop doing those surgeries over time. So then that kind of raises your wait list up, and you end up with an additional 320 Cat 2 patients that you didn't have on there before, an additional 304 category 3 patients that you didn't have before. And that dotted line kind of shows, how that doesn't actually go away unless you start making an active effort to do something about it. And so what this tool then enables you to do is take a couple of different approaches. You can kind of define at what point in time you're going to start dealing with that backlog. And then you can kind of play it out by capacity so that we know that our category 1s might not have actually changed because we continue to treat those throughout COVID. But we know that we need to start seeing some additional category 2s and 3s. So if there was a set capacity that you thought that you could meet, you can kind of change your numbers here, and you can say, well, if we did an additional 6 category 2s every week and maybe an additional 5 category 3s every week, how long is that actually going to take to recover? And so we've got about 54 weeks to recovery for our category 2s and 61 weeks for your category 3s. And you can see up here that that's kind of if you started that program next week on the 7th of February, then you're kind of not going to catch up until January next year. On the opposite kind of way of looking at it is if you were trying to meet a certain deadline. So say you needed to get all of those kind of surgeries back down to that normal level by the time by the end of the financial year, so 30th of June 2021, or you can kind of put whatever date you really want in there as well. What that then means is that you need to be finding the capacity or finding a method to be able to treat an additional 16 category 2s every single week and an additional 15 category 3s every single week on top of these kind of treats that we've already defined up here.
Fantastic. Thanks, Sam. So at the moment, the model's quite simple. We'd encourage you to log on and have a play with it, try and break it, have a look at some of the scenarios, sit down with your operations or your surgical teams and discuss some realistic approaches to that. Even just looking at the annual growth rate in those weekly additions, if you scroll down just quickly for me, Sam, please, we can see, trying to add in the purple and blue colours there, adding an additional 16 plus 15, so 31 procedures in a given week, as your directors of surgery and COOs would know, is quite challenging. Are we going to do it with Thursday night twilight lists? Is it moving to more all-day lists? Is it Saturdays that we're going to do? We don't have a cost component built into that, nor necessarily an activity funding component, but there's the capacity to do that. There's the capacity to eventually get that down to a DRG or a specialty or even a procedure level. So you've got much greater detail to be able to run through the scenario and actually be able to model some particular approaches that you might take. But yeah, we do encourage you to jump online and have a play with it. I think as you do that, you'll start to identify areas of improved functionality. What you may find is that the challenge becomes almost insurmountable within your existing resources, both physical infrastructure and capital and financial. And so that we do need to, as always, return to some some supply side challenges, and they are, what is the quality of referrals we're receiving from general practice to outpatients? How do we prioritise those? Has our waitlist been cleansed post-COVID? And what's the quality of those audits? Are we having conversations and really clearing out our waitlist for low-value care opportunities? Are all of the evidence-based prehab and rehab avenues being explored first prior to intervention? Community pathways, are we having quality of life conversations? So we still need to do that demand side conversation rather than just focus on how challenging the task is. Of course, we're doing amidst significant financial challenges. I think talking to some of the major public-private hospitals in the Eastern Seaboard, there's a lot of fatigued surgical teams out there that are being asked to sprint once again. Many of them are calling it the annual sprint, and I get a sense that the enthusiasm from those surgical teams is starting to wane. So they certainly would like to see more proactive forecasting and planning around how these volumes, which are relatively consistent, as you can see by the incline of the curve there, how they're going to be tackled from a strategic perspective and then from an operational perspective. So I think it's a good conversation starter. I'd love to the opportunity for Aginic and Green Cup to have those conversations with you and see what additional functions you think you might like added to the tool, or some tweaks to the coding or the maths. We'd really enjoy that opportunity to have those conversations with you. I'll just flag and doff my cap to Prof. Martin Connor, who's a long-time contemporary of both Green Cups and Aginics. Martin's posted a LinkedIn article, early COVID days, an internal memo to any state department, which sort of triggered our thinking around this, and we've progressed it further with the maths. So kudos to Martin for that. I think that's enough out of me. Have you got any other points you wanted to raise, Brett or Sam?
Sure. Before I let you run away, I was just going to ask this: that last section of the tool calculates how to get yourself back to norm. But as you said, the annual sprint concept is the norm. The norm is the norm where they want to be. How were people before theatre stopped?
Look, broadly, we'd seen significant improvements in the last decade across since really activity-based funding came in and these national measures. We've seen significant improvement, and so we don't have the super long waiting list that we had probably 10 to 15 years ago. There's incremental improvements that still need to be made. There are still single-figure digits in terms of percentages of people outside the waiting time appropriate clinical waiting time criteria. The concern which I raised previously is and the hypothesis from a lot of leading surgeons and public health physicians is that patients are presenting to their general practice later and hence are referring later. So we don't know yet, but we're expecting a drift upwards in the categories from the category 3s that are now 2s and category 2s that are becoming 1s because of their later presentation and their increasingly complex in acuity. The consistent surgeries, for example, in colorectal and upper GI, are quite concerned that they haven't seen the similar volumes which track very consistently year on year. So they do know that there are a range of patients out there that haven't presented to their GP for whatever reason, or haven't made it through to the system, that do require surgery because they're very consistent numbers each year. So that adds to the challenge, not just volume-wise, but acuity-wise. We'll probably see an upshift from 3 to 2s and 2 to 1s.
Yeah. Okay. All right. Well, thank you, guys. Just to kind of cap it off, I guess worth pointing out, this is just a quick demo. Aginic and Green Cup offer a range of services. So from the sort of less complex end, this kind of thing, through to much more complex analytics where we could take the time to really unpack things. It's probably also, just following on from what Sean said, worth docking the cap to Prof. Martin Connor's product, Healthcare Logic's System View, which is the sort of more real-time version of all this, next generation, if you like, Bloomberg terminal for a hospital, and a real focus on performance improvement. So whatever the needs are, by all means, give us a shout via our website, aginic.com. And in the meantime, hopefully you find this tool useful. Thank you.
Thanks, everyone. Thanks, Sam. Thanks, Brett.